I am Dr. Shirjil and you are watching my YouTube channel. If you like my videos, my ophthalmic science and other detailed videos, then don't forget to subscribe my channel so that you should be updated about future content. Now here I am solving the ophthalmic science 23 case. I was surprised that not a single viewer correctly diagnosed the ophthalmic signs, all the ophthalmic signs in this video. Like you can see, I showed you a young boy who had red eyes. He is photophobic, sensitive to light, with watering of the eyes. You can see the conjunctivitis. Right eye had opaque and edematous cornea. Now let's refresh our past knowledge. Corneal edema in allergic conjunctivitis kid. Now how can it happen? Or in other words, the kid has got vernal keratoconjunctivitis patient and he has got opaque cornea with sudden onset. Well, as you all know, what we see kids do, they rub the eyes vigorously. Rubbing changes the corneal shape, ultimately leads to the formation of keratoconus, and in keratoconus patients, when decimate membranes ruptures, it can cause sudden influx of aqueous into the corneal stroma, leading to corneal edema and opacification that can lead to acute red eye, painful red eye with sudden decrease of vision and white cornea. Now I think you have got this case, that this is a case of vernal keratoconjunctivitis induced keratoconus with right eye acute hydrops. Now what are the risk factors for developing acute hydrops? Well, the two most common risk factors are atopic disease like vernal keratoconjunctivitis and eye rubbing. Like in our patient, both these risk factors were present. Other risk factors are learning disabilities, steep corneas, high keratometry, Down syndrome, stromal thinning. Now how to prevent acute hydrops? Well, stop the kids from rubbing their eyes in VKC, treat vernal keratoconjunctivitis, avoid all the allergens. Acute hydrops patients present with sudden onset pain, decrease of vision, photophobia, red eyes and IOP may rise in acute hydrops. Now interesting fact is that actually there is a rise in intraocular pressure, but when you measure the intraocular pressure in corneal edema setting, it will erroneously comes low. So you should take into account that if IOP is coming in a normal range, it is actually increased. Now there should be diffuse corneal edema or corneal edema in a portion of cornea including the cone and decimate detachment. Corneal section will reveal large corneal thickness or increased corneal thickness. Signs of the disease like keratoconus and vernal keratoconjunctivitis should be assessed in both eyes, as anterior segment OCT is a valuable tool in the diagnosis of acute corneal hydrops. It can pinpoint the rupture in the posterior stroma and decimates membrane. It can monitor the resolution of the disease as well. The other important tool is ultrasound biomicroscope to diagnose, assess and monitor the disease progression and resolution in acute corneal hydrops. Now it can also show the reapposition of decimate membrane after intracameral air or gas bubble injection. Now what are the differential diagnoses of corneal hydrops, acute hydrops? Well, Acute congestive glaucoma, keratoconus, keratoglobus, pellucid marginal degeneration, keratitis, pseudophakic bullous keratopathy, Fuchs endothelial dystrophy, and rejection in corneal transplant, they all can present with a similar picture. So history is very important as well as clinical examination. Treatment includes medical as well as surgical. Medical treatment, like in this patient I have given full blown medical therapy with topical anti-glaucoma drops to decrease intraocular pressure, hypertonic saline drops to draw the fluid out of corneal stroma, to clear the cornea, cycloplegics to relieve the pain, steroids to decrease the corneal intraocular inflammation, antibiotics for infection. And what is the surgical treatment? Well, temporary and definitive treatments. As acute corneal hydrops occurs due to decimate membrane detachment, pneumatic desmetopexy may be considered to aid in treatment in this kid. I also put intracameral air injection along with medical treatment, and I will share its follow-up. Gases like C3F8 and SF6, if available, are better because gas remains in the anterior chamber for longer duration than air. But one thing you must know, both intracameral gas or air can reattach decimates and clear the cornea early, but on the final visual acuity these have no effect, or in the end need for corneal transplantation. Other definitive surgical options are endothelial keratoplasty, especially early in the corneal hydrop settings, because it lessens the need for full thickness keratoplasty. Decimate stripling automated endothelial keratoplasty and decimate membrane endothelial keratoplasty can be done. And in cases of resolved corneal hydrops that results in vision compromise due to corneal scar formation, we have got two options: DELC and full thickness penetrating keratoplasty. These have also got good results. Now, what are the complications of acute hydrops? Well, the most common and most important is corneal scar formation, keratitis, corneal perforation, pseudocyst formation. Now, as acute corneal hydrops resolves over a course of 2 to 4 months, as cornea heals, scar formation occurs. For scars outside the visual axis, vision can dramatically improve because of flattened post-scar cornea, and it also allows for easy fitting of contact lenses. But that's not the case in majority of cases. In majority of cases, scar formation decreases vision because it forms in the visual axis. In what cases the prognosis is worse? Well, prognosis is worse in cases when in acute episode of corneal hydrops, large area of cornea is involved, like diffuse corneal edema, and longer duration taken by corneal edema to resolve, and neovascularization of the cornea during the course. So that was all about the acute corneal hydrops in vernal keratoconjunctivitis patient, and I hope you must have learned something new. Thank you very much, and keep watching my channel for new ophthalmology stuff.